Birth is an extreme environmental shock. In an instant, a fetus is expelled from a warm, fluid-filled, strictly regulated environment into a harsh, dry, starkly different space. Survival requires an immediate, massive physiological pivot. To stay alive, the newborn must simultaneously execute three critical adaptations: clearing fluid from the lungs, shifting internal blood pressure gradients, and balancing rapid heat loss. This is the extrauterine triad. For 9 months, the placenta provided all oxygen. Now the lungs must immediately take over. The newborn has to pull in air, inflate the alveoli, and establish independent pulmonary gas exchange within seconds. At the same time, the infant is fighting the physics of the room. A newborn has a massive surface area to mass ratio and lacks insulating subcutaneous fat, making them highly vulnerable to rapid heat loss in standard room air. During this golden hour, the neonatal nurse acts as the primary safeguard, actively evaluating the success or failure of this complex biological pivot. The APGAR score, executed at minutes 1 and 5, translates transition into 5 metrics: heart rate, breathing, muscle tone, reflexes, and color. Acrocyanosis scores 1. Central cyanosis scores 0, indicating hypoxia. Vital thresholds are strict: heart rate 110 to 160, respiratory rate 30 to 60. To protect these vital signs, the very first physical nursing intervention is vigorously drying the newborn. Newborns are covered in amniotic fluid, making evaporative heat loss their immediate threat. Failing to dry the infant instantly is a severe clinical error. Leaving them wet allows rapid cooling, which triggers cold stress, a condition that quickly cascades into life-threatening hypothermia and hypoxia. When adults get cold, muscle activation causes shivering to generate heat. Newborns lack the neurological and muscular capacity to shiver. Instead, they rely on non-shivering thermogenesis. They metabolize stores of brown adipose tissue found around the back, kidneys, and neck, accelerating heat production through a process called lipolysis. There is a strict physiological catch to this mechanism. Burning brown fat demands an immense amount of oxygen. A hypoxic newborn cannot produce enough heat. This diagram maps the 4 specific vectors of environmental heat loss in infant faces: evaporation of fluid from the skin, conduction to cold surfaces, convection from air currents, and radiation to cooler nearby objects. Conduction is particularly hazardous in a clinical setting. Placing a newborn directly on an unprotected cold metal scale will rapidly drain their body heat. Always place a warm blanket or pad down first. Proper thermoregulation keeps the newborn's core body temperature within the expected reference range of 36.5 degrees Celsius to 37.5 degrees Celsius. The primary exam trap to understand is that cold stress directly causes hypoxia and hypoglycemia. Maintaining the infant's temperature is a critical respiratory and metabolic safeguard. The mechanics of the first breath drive the cardiovascular transition. Pushing air into the lungs expands the alveoli, and it forces a massive decrease in pulmonary vascular resistance. This schematic shows the fetal heart and the 3 shunts that allowed blood to bypass the inactive liver and lungs in utero: the ductus arteriosus, the foramen ovale, and the ductus venosus. With the influx of newly oxygenated blood and the sudden shift in atrial pressures from that first breath, these shunts are forced to close, routing blood through the lungs for the first time. Because this structural transition takes time, hearing a transient heart murmur during the first 24 hours of life is an expected clinical finding. While irregular respiratory rhythms can be normal, visible signs of distress are not. Grunting, nasal flaring, and chest retractions indicate severe struggle. The internal cardiovascular system has time to adapt, but external structural signs of increased breathing effort are never normal. They indicate the transition is failing and require immediate clinical escalation. The physical head-to-toe assessment acts as a continuous sorting mechanism, systematically isolating expected variations from true anatomical anomalies. Looking at this cranial cross-section, the left side demonstrates caput succedaneum. This is harmless subcutaneous swelling caused by pressure during labor, and it typically crosses over the skull suture lines. Contrast this with the right side of the screen showing a cephalohematoma. This is subperiosteal bleeding caused by vessel injury, and it is rigidly contained between the cranial suture lines. This rigid presentation demands attention. A cephalohematoma involves trapped, degrading red blood cells, which significantly increases the newborn's risk for developing jaundice and sepsis. Moving down the body, the provider performs the Barlow and Ortolani maneuvers on the hips. Feeling a distinct click or clunk indicates joint dislocation, pointing to developmental dysplasia. The spine must be inspected for deep sacral dimples or hair tufts located above the gluteal cleft. These are visual markers that indicate underlying neural tube defects. A systematic approach is mandatory. Missing anatomical findings in these specific zones delays vital diagnoses and directly increases long-term morbidity for the child. Early nursing interventions are highly predictable. They are explicitly designed to fill physiological gaps caused by the newborn's immature organ systems. The newborn liver is immature and lacks the intestinal flora required to synthesize vitamin K-dependent clotting factors, specifically factors 2, 7, 9, and 10. To prevent hemorrhagic disease and internal bleeding, the administration of a prophylactic vitamin K injection shortly after birth is mandatory. Likewise, to prevent ophthalmia neonatorum, a conjunctivitis causing permanent blindness from bacterial exposure in the birth canal, newborns receive a prophylactic dose of erythromycin eye ointment. This clinical timeline shows why universal newborn screenings are delayed. We wait until the infant reaches the 24-hour mark before the pulse ox and heel stick tests are clinically viable. The pulse oximetry screen for critical congenital heart disease is conducted on the right hand and either foot. A passing score requires an oxygen saturation greater than 95%, with less than a 3% difference between the extremities. The metabolic heel stick screens for inherited disorders like PKU and congenital hypothyroidism. It requires a full 24 hours of protein ingestion from breast milk or formula to accurately detect metabolic errors. The first 24 hours in the nursery consist of an active pharmacological gap-filling process until the newborn's independent systems fully mature. Environmental safety dictates strict, non-negotiable rules for preventing sudden, unexpected infant death. The newborn must be placed to sleep on their back, on a firm, flat mattress, with absolutely zero soft items, blankets, or bumper pads in the crib. Infection control requires precise umbilical cord care. The stump must remain dry, clean, and exposed to the air, without the application of antiseptics, staying entirely outside the diaper line. Because newborns undergo painful procedures like heel sticks and injections, we use the neonatal infant pain scale. This metric objectively assesses pain by evaluating facial expression, the nature of the cry, and breathing patterns. Coping with an infant's pain or crying is a critical safety issue. Inconsolable crying can trigger severe caregiver frustration, creating a high risk for shaken baby syndrome, an abusive head trauma that causes subdural hemorrhaging and permanent brain injury. Teaching parents safe sleep practices and effective coping mechanisms for a crying newborn is a life-saving intervention. It is equal in clinical importance to any medication administered in the hospital. Here are the 5 critical clinical rules of newborn care. Rule 1. Dry the baby immediately. Evaporative heat loss is the primary enemy of the golden hour. Rule 2. Inspect the skull. Differentiate harmless caput, which crosses suture lines, from cephalohematoma, which is rigidly contained and risks severe jaundice. Rule 3. Know the strict parameters. The heart rate must be 110 to 160, and respiratory rate 30 to 60. Intervene immediately for structural distress like grunting or retractions. Rule 4. Administer targeted prophylaxis. Use vitamin K injections and erythromycin ointment to protect immature organ systems before they can fail. Rule 5. Enforce safe sleep protocols. The crib must be completely empty, with absolutely zero exceptions. The nurse's precise execution of these protocols is the exact mechanism that guarantees the newborn's successful transition into the world.